So using similar principles, we can look at filling pressures. If you put a pulse wave, so you're just looking at the flow at the mitral valve tips, and you look at diastolic flow. So when the LV is being filled by whatever's in the left atrium. When the mitral valve opens, that first velocity is your E velocity. And that is both a function of how briskly the LV is relaxing and pulling blood into the LV, but it's also driven by the left atrial pressure. So if the left atrial pressure is high, that volume, that E velocity is going to be higher. And then the LV fills, and if the patient is in sinus rhythm, they're going to have this A velocity. This is atrial contraction. It's going to push the last bit of volume into the LV. Similarly, when you are looking at early diastolic filling and you're looking at the tissue Doppler, so how is the tissue moving? That first velocity where the LV is relaxing briskly is your E velocity. And what we know is that this ratio, the E over E prime, it correlates with your left atrial pressure. So in the literature, we know that this E over E prime greater than 14 is indicative of increased left atrial pressure. And this is something you can also use at the bedside to get a sense of whether somebody's volume overloaded or not. Your CVP, I think we're all very comfortable using, the IVC, but you don't want to use it as the only assessment. But again, you want to look at it in expiration 1 to 2 centimeters from the IVC right atrial junction, and normal is 1.2 to 2.1 centimeters. Now, the way that the IVC collapses with inspiration, so we usually have patients, inspire or do a sniff test. If their IVC is smaller than 2.1 centimeters and it collapses more than 50%, we give that right atrial pressure. We expect that it's around 3 millimeters of mercury. If the IVC is smaller than 2.1, but it doesn't collapse, or it's larger than 2.1, but it does collapse, then that's an intermediate right atrial pressure of 8 millimeters of mercury. And someone who's dilated and doesn't collapse, we expect that their filling pressures or their CVP is quite high at 15. So going back to our patient, and if the patient has a low ejection fraction on echo, it's important to note that EF is dependent on loading conditions. It's not equal to cardiac output or volume status, and consider these calculations to give you a better assessment of both cardiac output and filling pressures to get a better sense of what's going on with the patient.